This is Rick Mattson from the Shoulder and Elbow Service at the University of Washington. We're talking about how to do a total shoulder, specifically with how to manage the frequent problem of glenoid retroversion. So what that means is that the glenoid normally makes an angle of about 11 degrees or so with the long axis of the scapula. But in many arthritic cases, the glenoid is retroverted, as is shown by this green line. We don't need to get a CT scan to find out if their glenoid is retroverted or by how much, because we use what we call the axillary truth view, and that reveals, again, that many arthritic glenoids are retroverted. There have been several approaches that have been described for managing retroversion, and there are the folks that try to correct glenoid version, some by reaming the anterior glenoid bone, that would be here, some by adding a posterior bone graft back here, and some by using a piece of plastic that's built up in the back, or a posteriorly augmented glenoid component. Our approach is to accept glenoid retroversion. So, approach number one is reaming the anterior bone. But what you see here, in an attempt to correct glenoid version, this reamer is removing a lot of bone. And that takes away some precious bone stock and takes away the cortical bone, which is the strongest bone for supporting the glenoid component. So what it does is reduces the amount of bone support and gives us less bone on which to place our component. Another approach is to build up the back. And that seems straightforward, but actually technically it's difficult because we have to make a posterior incision for getting that bone graft properly positioned and getting a screw in to fix it into place. And then once that is accomplished, then we have to go back to the front of the shoulder through a different incision and ream that glenoid bone so that it will fit the back of the component. A third approach is to use a posteriorly augmented glenoid, such as this stepped glenoid shown here. And that involves removing some of the bone in the back of the shoulder and then putting this special glenoid component in to fit that shaped glenoid bone. But you can see again that a fair amount of the bone is removed, so that should this glenoid component fail, we are left with a substantial glenoid bone defect. So our approach is to accept glenoid retroversion. And so in brief, the way we go at this is to remove the cartilage from the front, burr down the crest between the anterior and posterior concavities, then ream it so as to remove the smallest possible amount of bone necessary to create a single concavity. Most often, that shoulder is stable with a conventional humeral component. Sometimes, however, there's a tendency for posterior translation, in which case we use an anteriorly eccentric humeral component to balance the ball in the socket. And that is shown in this X-ray, where you can see that there is a lot of glenoid retroversion, but the shoulder is balanced with the ball in the center of the glenoid face using this anterior eccentric humeral component. This, for us, is a very versatile technique and has been associated with high survival rates without having to use any of the other techniques described. So again, our approach is to accept glenoid retroversion using conservative glenoid reaming, a standard glenoid component, and if necessary, an anteriorly eccentric humeral head component. And here's another example of a very nicely fixed standard glenoid component in a retroverted bony glenoid. Thank you.